I'm going to present a couple of cases for post-operative conservative management. We only really got through 2 of the cases downstairs. I had to speed show the third case. Downstairs, I think it's 216. You'll, yeah, one level. It's not the lounge. So I'm going to present a couple of cases, and to show you what my decision-making was through the cases, because we've already established there really is not a standard, but I'll explain to you what my decision-making was, and we can kind of discuss, would you have done something differently, or if you have any questions as we're progressing. So the first patient, okay. Upper extremity lymphedema for 13 years after breast cancer treatment. The treatment consisted of partial mastectomy, axillary dissection, chemo, radiation, and I made a note of a more recent ORAF for wrist fracture on the involved side. So in thinking about volume difference, that wrist is probably going to be a little bit wider, so we may not resolve the volume completely. When we first saw her, she had about 4 millimeters of pitting, mostly on the posterior medial upper arm and the forearm, the whole forearm and hand. And if you remember from the anatomy discussions, that posterior elbow, just above the elbow, and the medial forearm would tend to be the worst areas. Her lymph QOL was 66. And for compression, she was wearing a Solaris night garment 20 hours a week. So it was really not every night. It was just some nights and nothing else. And going and doing self MLD. Periodically, she would go and see a lymphedema therapist for MLD, but found that increasingly over the years, compression just didn't work for her, so she stopped using it. She was from out of state, so she had a lymphedema therapist close to home. And again, as I said, she would see that person intermittently. She was exercising regularly, at least 150 minutes a week, doing a combination of walking, yoga, and weight training 3 times a week for an hour. So she was getting, what we would consider recommended amounts of exercise, and that was going to be well, fit for her lymphedema. Her patient-specific functional score was 1.33 out of 10 on the low side, and she felt really inhibited by the symptoms in her arm and the weight of the arm, that it slowed her down and it made it more difficult to do everything. And she came to us for surgical consult because, she wanted a variety of things. She wanted her arm to be smaller. She wanted not to have to wear so much compression, and she was only wearing it 20 hours a week. So, and she wanted to make sure that the disease didn't progress. So that was a concern. She didn't want it to get any worse. She wanted to make sure she was doing all she could to keep it under control. So after workup, it was decided that she had really more fat-dominant disease than fluid, and it was decided that she would have a surgical debulking. So she underwent a surgical debulking and was put in, per protocol, a post-op Elverex class 2 sleeve and glove that she started right after surgery. 3 months after surgery, her volume was down to minus 1.4. It was probably down to close to that right after the surgery, and that was just a result of the surgical debulking. It had nothing to do with the compression. Really, the compression was there to make sure we didn't allow any fluid to accumulate and start that fat hypertrophy process all over again. So her LDEX was 41, so the LDEX was down, indicating that she had some reduction in the extracellular fluid. So even though she did not have a physiologic procedure, we see improved fluid control, and I attribute that to really the heavy-duty compression was really holding her well, especially compared to what she was wearing preoperatively, which was nothing during the day. So the compression stayed the same. She was in the same garment that was made for her and given to her on the day of the surgery. So it was still within its lifespan, it still fit well, and it seemed to be doing what it was supposed to be doing. So at the 6-month mark, we can see that the volume ticked up a little bit, 3.2. Might be that the garment was getting a little bit older. Her LDEX was about stable, and we recommended garment replacement because it was at the end of her lifespan, so we got her a new garment. and she lived out of state, so we had her fitted for a garment, and the garment was sent to her. So at 9 months, her volume was up to 5.8. So now there's two measurements where her volume is going up. And so for somebody with lymphedema, you might think 5.8 is not a huge difference. But it's a trend. It's starting to become a trend. So I'm going to be concerned we have to change something in this protocol to make sure we get that volume back down again. Her LDEX is somewhat stable, 46. It's ticking up, incrementally in small amounts. But and so what happened here when I asked her about what she was doing with compression really was not following through with the protocol for a variety of reasons. The major one was COVID had hit, and she wasn't able to go and get a new garment because they closed down. There was no place to go. Our fitters, there's no place for her to be seen. So she had reached out to somebody, and I couldn't really identify who did some measurements for her. And she ordered a cut and sew garment, which if you've seen those, they're kind of a much thinner material than the LE&RN flat knit, but it was custom made for her. So a very lower level of compression and lower ability of that fabric to hold. So I suspect it was allowing some more fluid to accumulate. So that's why I attributed that to the increase in volume. So at this point, we got to get her back into a flat knit garment, something that can hold her edema a little bit better. How are we going to do that in the middle of COVID? Well, when she came in to see her, we took some measurements that day so that we could order something for her. Normally, our lymphedema therapists don't do a whole lot of measuring. We have somebody measured by fitters, and most of it just has to do with our time and efficiency, but we will take some measurements. I usually don't do measuring, but the other two therapists will do more of the custom garment measurements to get it made for her. So I wasn't going to let her leave without getting measured because I just wasn't sure. She didn't have any resources near her to get fitted for garment, especially at this time. We were still under somewhat restrictions with COVID. And so she was back in a custom garment. Oh, we have a question? Yep.
Sorry to interrupt, if that's okay.
Yeah, absolutely.
Is when you're measuring people, are you measuring contralateral when they're in the protocol later on, or are you measuring
No,
them?
we're measuring the true size. In fact, what we will do is not only measure the true size, but if we start to see the volume increasing like that, I'm going to be very vigorous in pulling that tape measure closed,
Okay.
tighter.
So you don't want to keep
to reduce it.
accommodating to it either.
I don't want to accommodate. I want to actually go in the opposite direction. I want it to accommodate to me, so I'm going to pull it a little bit tighter.
Yeah. All right. Thank you.
Because if I just accommodate, she's going to go a little bit more, and I'm going to expand it a little, and I want to go in the opposite direction. I'm going to take it in enough that it provides a little bit more compression. I'm reducing the circumference, so by that it's increasing the. I'm not going to pull in the wrist measurement or right at the elbow where it might impede the joint and cause some discomfort. But I'll, especially the forearm and the upper arm measurements, we would pull that in. So at 1 year, her volume is 4.4%. Her LDEX is 40.8, and she's wearing the LE&RN sometimes. She's wearing the LE&RN sometimes, and she's alternating with the cut and sew garment, which she finds much more comfortable. And I get that. It's less compressed, and it's a thinner material. I'm sure it is more comfortable. And sometimes, as multiple people have said, sometimes you have to meet the patients where they are, but also have to tell her that explain to her about the post-op protocol is put together for a reason, and I really don't want the fluid to reaccumulate and start that fat hypertrophy process all over again. So it's really critical that she's wearing something that's going to hold the edema better than this alternation back and forth. And so by showing her the numbers, you can see that I'm looking at the volume, and again, these aren't huge numbers because she started at minus 1.4, but if we look at the three successive measurements, it's an upward trend now. So I just wanted her to understand that, and I don't want the volume to go in the wrong direction. So she completely understood that, and she thought about it, and even when she left, I thought to myself, I wonder if she's really going to do that. I thought maybe that she would put the garment on, the LE&RN on every day, but I wasn't really quite sure. So I was just kind of holding my breath until she came back again. And I had the appointment for her to come back not 3 months later, but 1 month later. I just wanted to check, and I really told her I was really concerned, and I wasn't going to let her go at least more than a month without her coming back to see me. And her volume was 1.9%. Yes. And the LDEX went down to 30.3, so telling me there's less extracellular fluid, and the volume is coming down as a result. going in the right direction. So I thought this is good because she's about just a little over a year out, and we would expect her down. Dr. Single would like her to see the volume at close to zero, if not in the negative numbers. So we were much closer to that. And she stayed in pretty good control, and she stayed wearing the same compression garment, again, over the next year. So we're following patients every 3 months, and they come back for an annual review with the whole team once a year. So she was getting ready for her annual review at this point. At 22 months, 0% difference. The LDEX is 22.6. Again, continuing to come down despite the fact that she didn't have a physiologic procedure. I wouldn't expect it to come down much more than this. It's never going to be in the normal zone because she's got lymphedema and she's always going to have a little excessive extracellular fluid. So as far as the compression goes, she's going to be in the same compression. And I put a note up here, consider wean after 2-year follow-up, but that is after she has a lymph node transplant, which is she was being under consideration for. So we're not going to start weaning the compression until after she has a physiologic procedure. So we're out of COVID at this point. She's able to get her garments refitted and remeasured on a regular basis and replace them until that she is scheduled for a lymph node transplant. And then after that, our goal would be to wean her from compression. So she was a success, not totally online with the protocol, but we'll give her some leeway because she survived COVID and improved to this degree. So that's kind of my thinking as we go through with all these measurements. And then these are her pre-op measurement and then 1 year post-op, and you can see the improvement. In the left upper extremity above with a little bit more fluid. There was a 51% difference, and the picture does not really do her justice because the most of the, if it was a 360 circumferential image that you saw, you'd see there's more fluid on the posterior upper arm if we did a 360-degree view. So it doesn't even look as bad as it really was. And then post-operatively, 4.4% at 1 year. The LDEX was 44 at that point, and her LymphQL score went down from a 66 to a 36. So she was quite pleased even at this point when she was alternating the two garments, that she was quite pleased with the outcome. So this patient, another one, patient who had breast cancer-related lymphedema, she had it for 5 years before she came to see us, after having had a mastectomy and axillary nerve dissection, neoadjuvant chemotherapy and radiation. Her BMI was 31.1 and stayed pretty stable over the course of our, post-operative measurements. Volume difference initially was 21.6%, and her LDEX was 18.6. She had minimal pitting along the ulnar forearm and the hand, especially the dorsum of the hand. Her LymphQL was 55, and she was wearing a flat knit custom sleeve all day, and she was bandaging at night. Intermittently exercising. She had a job that required her to take care of children, and she also liked to cook and had a lot of family responsibilities. And so most of her complaints involved around not being able to use her arm like she wanted to enough, and having to wear compression and needing to take the compression off if she wanted to do chopping, food preparation, and cooking. So it really revolved around the limitations because of the compression and the size of the heaviness of her arm. So she was determined to be what we would call fat dominant after a workup, and she was scheduled for for a surgical debulking. And these are her pre-op numbers. She underwent the surgical debulking, and after 3 months, she was at -3%. And her LDEX was 26.7, and she was wearing compression, basically 24/7, Alvarez class 2. And she was very meticulous in following through with compression preoperatively, so I really had no doubts that she would do the same thing postoperatively. Postoperatively at 6 months, she was at -12% volume, which kind of surprised me a little bit. I didn't expect it to jump that low, but she was also having some problems with the garment. It seemed to be fitting. It was too tight in some places, so I wondered whether or not we just didn't have her in the right fitting garment. It made it to be remeasured. I didn't want her volume to increase, but I just thought that was a kind of a big jump. So we got her garment refit and remade for her, and it was more comfortable. And at 9 months, she was at -6, which is kind of more of what I would expect at this point. Usually after the surgical debulking, volume continues to decrease, but it levels off at around 9 months in the upper extremity. And just about the time patients are coming back for that 1-year follow-up, it's kind of hit that level, because if patients are talking about having another procedure done, like a physiologic procedure, we want to make sure that they at least have at least 2 measurements 3 months apart that show that their volume is stable, so that they're able to maintain. We certainly don't want to interrupt and put a new surgical procedure if somebody's continuing to reduce. So we kind of want it to reduce, hit bottom, and then level off. Her LDEX, though, is kind of an impressive 14.1. So, you know, it's close into the normal range. So we have really good control of her extracellular fluid. So minimal pitting, and she seems to be doing well. So she would be ready from my point of view. She's following through what we need her to do. She looks good. Everything is stable and ready to go. At 12 months, she's at -5%. 21.3 is her LDEX. And she's getting another new set of garments. And then again, I didn't put the interim measurements in here. She ended up not having a lymph node transplant, or not having it done immediately. With, again, life happens, and it's not so easy to schedule time to have surgery. And oftentimes patients, especially when they get a big gain of function, you know, the arm is now a smaller size, it feels lighter, it's easier to do your work even though you're wearing compression. You know, it's maybe not so important to have a lymph node transplant. I'll take care of that later when I can work it into my schedule. So they might be scheduled down the road. And we still want to make sure that we monitor them on a regular basis to make sure they stay stable. Minimal pitting, and her volume stays fairly stable. So you can see 3 measurements, well, and all the interim measurements were really fairly stable. There may be a slight fluctuation. As the garments get older, it might go up a few percentage points, and the new garment, it might go down a few percentage points, but we want it to stay pretty stable. Her LDEX is down to 14. Her quality of life is a 40, she got a set of new garments, 2 months, and that's important because she just got the garments for 2 months, and then she had the lymph node transplant. If you remember, I said earlier, when somebody's having a surgical procedure after the lymph node transplant, 3 weeks out of compression, we want to put her back into new garments. I don't want those garments to be brand spanking new and very stiff, but I don't want them to be old either. So it was, timing-wise, a good time. And then 6 weeks after the lymph node transplant, you can see the volume went up. Post-operatively, there's going to be edema, and she's out of compression for 3 weeks. So that doesn't surprise me at all. I would expect that to happen, and I would expect it to go right back down again. And her LDEX is 17.9. And she had new garments 2 months before the surgery. She was out of compression, then 6 weeks after the surgery. So we ordered new garments, knowing that she probably wasn't going to get them for another week or two. So it's about time for her to get new garments. And so this is, and that was the last measurement I took of her. So it hasn't been that long ago that she had the lymph node transplant. So that's the last measurement I have. So looking at her preoperative numbers, 21.6% difference, 18.6 LDEX, and her lymph quality of life is a 55 post-operatively. After the debulking was -5.6, and the LDEX 21.3, and the quality of life decreased to 40%. So an improvement, and she was pleased with her progress. So after having the lymph node transplant, then my goal is to, once she levels off, to reduce her compression. So we'd keep her in that same preoperative compression, let that level off, so she gets back down to the nadir that she reached with the volume reduction after the liposuction, and then I would start to reduce the compression. And somebody, there we go. So there are, before I bring the last case, the case 3 up, somebody had asked me in the previous session, what's your decision making as in regards to reducing compression? So there's not one answer. The easiest thing to do, and oftentimes my go-to, is just to have somebody come out of compression at night, because gravity's working in our favor. And so, you know, all night out of compression is kind of almost like 4 hours out of compression during the day, or 3 hours of compression during the day. So it's, I mean, I don't worry as much about accumulation of fluid. So that's easiest to do, and oftentimes patients don't like sleeping with compression. Now, if a patient says to me, I hate wearing compression, during the day or particular, activity during the day. I don't mind wearing it at night. I'll wear it all night if you want me to. I just don't like wearing it during the day. Well, then my priority is going to shift. But I'm going to say, okay, you can take the compression off for 3 hours a day, and then let's remeasure you in a month and see what happens. I'm not going to let them go all day without compression. I learned the hard way is if I overestimate, and have them really take it off for like a whole day, and then I have to put them back in compression. Psychologically, that's more of a hit than if I just say, let's do it 3 hours, let's increase it to 6 hours, and they show good progress. So when we first started this, we started weaning much earlier and in bigger increments, and I'm not doing that as much anymore because I don't like to go backwards. I'd like to make progress. So as far as the philosophy, it might be that instead of wearing a class 2 Alvarex, we go to a class 1. If the biggest problem is garmenting and reducing the level of compression is the most important thing to them. I probably do that less often than number of hours initially. Once we get the hours down a little bit, I might go into a lower class of compression. But the easiest for me to know and to measure is to take some of the hours off. Now, if a patient wants to double up on their exercise, we might negotiate. Okay, if you do, double the amount of exercise, I might double the amount of hours that we can reduce you wearing compression. And let's measure the effect and see what we get. And then we will adapt the next time. And I might shorten the interval that I'm seeing patients as opposed to having them follow up in 3 months. If the effect is going to be less predictable, I might have them come back in a month and then make another change. So it's...
We have a couple questions from online. So one is, how many garments is a set? 3 gloves and 3 sleeves?
2 gloves and 2 sleeves is one set. So we have one set, a sleeve and a glove to wear, and one set that can be washed, and they can alternate them.
And then the next question is insurance covering all post-operative garments?
No. So very variable insurance. I wish they would, but just like preoperative garments or, somebody who doesn't have surgery, there's a wide variety on what gets covered. Medicare doesn't cover any compression garments. Some Mass Health plans will cover it with prior authorization. The private health plans, some cover up to a certain amount or some have a deductible. Blue Cross won't cover the custom code unless you're at least 30 millimeters of pressure, which isn't appropriate for some people. So some, they'll deny a class 2 custom garment because it doesn't hit that threshold. So the garment, the insurance policies don't necessarily make any sense. So we have some patients who are covered in full and some who have no coverage at all. That's one of the things that we talk to people before surgery, knowing that there's pretty rigorous requirements for post-operative management after the debulking, to know exactly what the cost is going to be. So we know if you need a full-length, sleeve and a glove, and you need 2 of them, and you need to replace them every 6 months, you kind of estimate what those costs are going to be, so they know going into it for each of the procedures.
In Western Mass, we used to have Rays of Hope, so you have some funding that you can tap into.
Yeah. We had I think I mentioned it yesterday, we had one of our research fellows applied for a grant through the Plastic Surgery Foundation, and we got a grant of $10,000. I think it was one of the breakout sessions yesterday. And it was for patients who had no insurance or had Mass Health or Medicare, which doesn't cover. That was great, but the $10,000 went by so quickly. Too quickly. So, right, some of the other people in that group also said there were surprising opportunities for grants out in the community and donors. I think Cheryl, if you want to make a comment about, you want to pass her the microphone, make her a comment about what she did at MGH for garments.
Yes, in the past there was a local women's group that we were kind of connected to through a patient, and we just approached them and did a presentation about our work and about the gap in coverage for garments, and for a few years they gave us $10,000 a year for garments for the underinsured. And then unfortunately, that no longer exists, but our OT and PT director has been very gracious. And as he said to me, we spend a lot of money on crutches and walkers and things every year. We can certainly give patients the garments they need. So he's been covering we've been covering if needed, but we have to be careful because, as you said, $10,000 goes very quickly. But I would look to the community for opportunities. Even, if you know of a local female-owned business and the CEO has been affected by breast cancer or some kind of cancer that may be associated with lymphedema, talk to them, tell them about your work, and maybe it's an opportunity to open a conversation.
Was there a question over here?
Oh, yes, I just wanted to know, what was your quality of life questionnaire?
So the question was, what is our quality of life questionnaire? And we're using the LymphQOL for the upper extremity and lower extremity. All right, so the last case I have, patient with, again, breast cancer-related lymphedema, and went through a course of neoadjuvant chemotherapy, axillary dissection, radiation, and her lymphedema began after the chemotherapy, before the radiation. She had multiple courses of CDT over the course of 8 years. I had been treating her for a long time before we even started our lymphedema program. And, she would have an exacerbation once a year, once every other year. And she's, one of the things I asked her, what's your purpose in seeking surgery? And she said, love to see you all the time, but I don't want to have to go through all these courses of treatment so often. She wanted better control of her disease, despite the fact that she was wearing compression. She would kind of have repeated episodes. So at this point, her BMI was 25.8 and it stayed pretty stable over the course of her treatment. Her volume difference was 10%. Most of that was in the forearm. Her LDEX was 14.5, and she was wearing compression about 8 or 9 hours per day, and not at night. She worked, at that time, she was working in a department store. So having the garment be visible was something that she was very cognizant of, working with customers. She didn't want them to ask questions about it, so that was another issue that she had. Her LymphQL score, overall score, was 37. So she was a pretty happy, satisfied person in her overall life, despite the fact that she had lymphedema and didn't want to wear the sleeve. So she underwent lymph node transplant. I don't have pictures of her because before Drew came and started the program, I never even thought to take pictures. There wasn't actually a way to upload any pictures into the medical record, so we didn't have the technology back in the dark ages. So I have pictures of the other ones, but not of her. So she was one of the first patients we kind of brought into the surgical program, one of the first. When he came on, I had a steady stream of patients who were like on my list of people who we kind of exhausted conservative measures and wanted to be seen through the surgical clinic. So after the lymph node transplant, 3 weeks, no compression. So at the 3-week mark, we would resume compression. We put her back into the same garment that she had. She was wearing a ready-to-wear sleeve before surgery, so that's what we put her in right afterwards. And being one of the earlier patients, that my approach to post-operative, has changed since then. So this was one of the earlier patients. So my plan was to put her into the same preoperative garment. We started bandaging her first, and at that point, what we would do is bandage right at the 3-week mark, and bandage the hand, from the MCPs all the way up to the elbow, and not bandage anything proximally. For the same reason that the lymph node, one of the reasons anatomically that was being placed in the forearm, but also gravity, fluid is going to drain with gravity down to that new lymph node. So we thought we would need the compression up into the elbow, and we might not need the compression pushing the fluid the rest of the way up. So at that point, we were just bandaging half the arm. And then we ordered her a new sleeve and glove. At 6 weeks, she had the new sleeve and glove. Her volume was 10%, LDEX was 18.6, and she was in compression, put her in the same number of hours of compression to start with a new sleeve and glove. Her numbers at 3 months really didn't add to our decision-making. She stayed stable, and I didn't make any changes. And her volume at the 9-month mark was 8%, and her LDEX was 4.8. And she was in compression only 28 hours a week. So 8% and a little bit of improvement in volume. Remember, with the lymph node transplant, we don't expect to see huge changes in volume. She didn't start with a big volume differential anyway, but I did see a reduction in the LDEX, so less extracellular fluid in her arm. So down from a 18.6 down to 4.8, so kind of in the normal range. And again, one of the first patients that underwent lymph node transplant, we started weaning her a little bit early than I would do now. And so we started cutting her number of hours in compression down to 28 per week. And then measured her again, and we saw her for a 9-month measurement. I just didn't put the numbers in there. They don't really add to our decision making. At 1 year, her volume continued to improve, and the LDEX was staying steady, and she was now in compression 0 hours per week. So again, we weaned her much faster than I would do now. Knowing in retrospect, having seen more patients and looking at the imaging and some of the changes that we see on imaging, we don't see them until well after the lymph node transplant. So, being a little bit more conservative in weaning patients now, whereas previously we weaned them a little bit faster. So at 2 years, and the interim measurement stayed pretty stable. Volume is 4.7%, her LDEX is 11, and she's still wearing compression 0 hours per week. And even at 3 years, her volume came down a little bit more, and her LDEX is now in the normal range, 1.6. She put her compression back on, feeling some symptoms, so intermittently was wearing compression. So when I measured her, I would ask how much you're wearing compression, really like over the last month, and have patients give an estimate how many days you're wearing it and for how many hours. So it was for symptoms. And then a year later, her volume is 0%, her LDEX is 7.6, and she's still wearing it 0 hours. She really didn't, and over the previous 6 months, had not had to wear compression. So she is basically out at 5 years now, wearing compression, no hours per week. Her LDEX still is in the normal range, and her volume stays pretty stable. Her LymphQL could not go too much lower because her quality of life was already pretty good. She has since retired. She's been doing some traveling. COVID interrupted that a little bit. So she's really pretty happy with her outcome. Yes.
When you mention travel, you say how she's not in compression day to day. Do you have her?
Oh, she's not flying for travel. She's taking, she doesn't fly. Sorry, I should have mentioned that. She took like a bus tour through New England, and she takes a train, and she goes on road trips with friends.
Would you encourage compression for a flight, or have you not come across that? Like in this person's situation?
I don't know that we've ever had anybody in that situation after a lymph node transplant that wants to fly. So I haven't had that discussion with patients.
What would you recommend, though? If that came up, what would you say?
Well, if she's going to fly, I would have her wear, if she's going to wear compression, I'd have her wear a glove and the sleeve to begin with. I don't know. I think I would probably want to err on the side of safety and have her wear the sleeve. Although I don't know if I would have somebody go out and buy a brand new sleeve if they were not wearing a sleeve at all ever. Maybe a ready-to-wear sleeve or something that at least fits her well, but not with a high level of compression. I don't know. What does everybody else to think? What does everybody else think?
I would, just to make sure. You know what the nice thing is, that a lot of sports now wear a lot of compression, so they can even get a pair of sports, basketball, whatever, compression sleeves that are not that high.
If she's wearing a sleeve, I'd want her to wear something, even if it was light compression, that really fit her well and didn't bunch up or like tourniquet on her arm. Patients who have gone through all of this are not going to mind wearing a sleeve on a flight. And what they don't want to do is have their swelling get worse. So I don't think they would mind wearing it. So I would probably err on the side of safety and have them wear it. But we're going to run into that the more that we do. If somebody gets to the point where they're not wearing compression ever and just wearing it for flying. Cheryl.
We don't have any evidence, right? So I agree with you. I would err on the side of caution, but my biggest concern would be ill-fitting compression. Absolutely. Sleeve and glove. If she has one that fitted her and you think it's still reasonable, have her try it for a few days before she goes away. If it fits well, then put it on. If it's uncomfortable on the flight, take it off. That's what I would tell her.
Yeah.
But we really have no evidence, so I would err conservatively.
Yeah. Right, I'd be most afraid of somebody not wearing compression, not having a sleeve on hand, and then ordering something on the internet that doesn't fit well and it could do more damage.
Yeah, I mean, I get a lot of my patients wearing a sleeve because athletes wearing it now. Like,
Yeah.
it doesn't look so weird anymore. I definitely not into the Jimmy Copper or any of that stuff, but I think it's easier for them to accept it
Right.
because,
And they can order sleeves in different colors. They look just like the sports models. They just, you can get them fitted for. So good point. And we may be running into that more and more often. Other questions?
We have
Angela?
a question from online. Do you ever see patients who present with very clear clinical signs and symptoms of lymphedema, but whose LDEX values remain within the normal range and without significant change from pre-op baseline values? If so, how do you interpret the LDEX scores?
So if somebody has a lot of, so I'm not sure if the question pertains to patients like we're doing surveillance, patients at risk for but don't have lymphedema, or somebody who has a diagnosis of lymphedema. I think I would think of those two as differently. If somebody had, I'll answer both scenarios from my opinion, and I'll open it up to what you all think. If I'm following for somebody for surveillance, they're at risk for lymphedema but don't have a clinical diagnosis of lymphedema, even if the LDEX is in the normal range and they're showing me symptoms, I'm probably going to pay attention to those symptoms. And I maybe give them an exercise program, maybe would fit them, depending on the severity of the symptoms, maybe fit them for a compression garment and follow them up at a shorter interval to see how they respond. I wouldn't let too much time go by before I would re-measure them. So, sometimes I maybe take the LDEX again. Sometimes I might not trust my measurement. If somebody has a lot of severe symptoms, I might want to take it again. So somebody who has no volume change and bioimpedance normal, but they're still having symptoms.
I think it's just about the LDEX, and this is more so if someone has surgery. So pre-op, they have a normal LDEX, but they get some form of surgery, and then what it is afterwards.
So for surveillance, I would pay attention to the symptoms, but wouldn't necessarily treat, and I'd follow them up at a shorter interval and see what the changes are. After surgery, if the LDEX is normal and they're having symptoms, I would do what I could to treat the symptoms. They have a diagnosis of lymphedema. I'm going to do whatever I think would reduce their symptoms. So it might be, again, doing exercise. It might be adding some compression.
And I'll just add, I think this is where the power of ICG comes in, because we've definitely had a few patients in our surveillance program where, you brought them to conference, you or Emily or Katrina, and said, look, they're in our surveillance program, they're having symptoms, but the numbers look normal. What do we do? And we'll follow them for 3, 6, 9 months, and then we'll say, let's just do an ICG on them. And if we do an ICG and it's all linear patterns, it's reassuring for all of us, including the patient, versus if we do an ICG and we see something different, like a stardust diffuse pattern, we're more likely to say, maybe we should just start some early compression. So I think ICG can play a big role in this.
Right. Okay. So we're really out of time.